will co-chair this session with Katerina Naka from University of Ioannina. And the speaker today is Ulf Landmesser, who is a chairman of the Department of Cardiology, Angiology, and Intensive Care Medicine. He's a professor of cardiology in Berlin, in Charité. I checked this hospital, Charité, and it scores as one of the top 10, or others say top 5 hospitals in the world for cardiology. So congratulations for that, Ulf. And the topic that we will discuss today is coronary artery disease, from the standard coronary artery disease research and treatment to more advanced. So if you want to take the stand. And the question is, did we believe that we covered everything on coronary artery disease? Is there anything else to do research on, and on different types of pathways, let's say pathophysiologic pathways? So you will probably tell us. Thank you.
Well, Apostolos, Katerina, thank you very much for the very kind introduction. Professor Flagakis, thank you very much for the invitation to come here to beautiful Thessaloniki. It's my first time here, and it's a great pleasure to discuss in the next minutes a little bit on what we think is important in coronary disease. I mean, we are all aware that coronary disease is still the main cause of death in our countries. I just brought you the numbers from Germany, which is actually a nice reflection of our really daily practice. And you see the orange curve is here the clinical manifestation of coronary disease. Starts at around 40 and then gets, of course, more with increasing age. And then you see the other curve, the blue curve, is arrhythmia. That comes a little bit later, but then it's the second frequent cause really of hospitalization in Germany. And then comes with increasing age heart failure, and then also at increasing age valvular heart disease. But you see coronary disease still remains the leading cause of hospitalization and death, at least in our country. And one of the tricky things about coronary disease you're all very well aware of is that frequently the first clinical manifestation is acute coronary syndrome or sudden cardiac death. And we already know from the Framingham study that it's in about 50% the first clinical manifestation. So if we really want to improve outcomes from coronary disease, we need to also improve, obviously, its prevention. And this is a slide from my colleague from London, Professor Dienfield, who always then mentioned that these people will never meet their cardiologist because the first event might already be, of course, a deadly event. And we understand very well why this is the case. So this is a disease that has decades long of development of coronary plaque, and then suddenly we have in about 70% is plaque rupture, the cause of the acute event. And we can, as you have seen in the previous session very nicely, by optical coherence tomography now understand the mechanism also in vivo in our patients. And you see here this plaque rupture, this is about 70%. The other 30% is plaque erosion, which I think we understand much less, and we are actually doing a lot of research now on trying to understand better the causes of acute coronary syndromes due to plaque erosion. Now, when we look at cardiovascular risk in Europe, and I looked also, of course, for Greece, so in Germany, we're very unhappy that we belong to the moderate risk region, which is also one of the reasons why we have so many interventions, because the overall risk in the population is high. And you have actually a similar situation in Greece, where it's also a moderate risk region, which means that the average risk in the population is higher than, for example, in France, Spain, or in the UK. So I think we definitely need to get better in the prevention. And we have just seen in the last year, I think, a very nice publication coordinated from the colleagues in Hamburg in Germany, where they really looked in the population how much of the risk of cardiovascular disease is actually related to the classical risk factors. And the leading risk factor in the population clearly is hypertension. You see this here, that's in the population, the main cause, not only of coronary disease, of course, but also atrial fibrillation, heart failure, and others. Then dyslipidemia or non-HDL cholesterol more specifically is the second leading cause in the population. Then comes diabetes, body mass index, of course, obesity in particular, and smoking. And the interesting things, all these are modifiable risk factors, and I think we clearly need to get better at earlier detecting them and more consequently treating them. Of course, it doesn't explain all of coronary disease, and we have been hoping from the genetic studies to get more insights in the causal mechanisms of disease. And of course, in the genetic and genome-wide association studies, blood pressure comes also up, or blood pressure regulating genes, the lipid metabolism. But you see, there are also areas which we are not targeting clinically, I think, very well, and it's particularly the area of immune regulation, which is very important for progression and complications of coronary disease and thrombotic mechanisms. And of course, as you see here, there are very many unknowns. So still, we don't have completely understood the predisposition to coronary disease. I think one way we can use this, and there was, of course, a bit of disappointment because there was the hope with the genome-wide studies, we identify the causal genes and then we get treatments and can get even better in our management. And what it turns out is that all the genetic variations contribute, each of them very little. So you really need to look at polygenic risk scores if you want to get an input from the genetic risk. And what we did here together with our Digital Health Institute at the Charité in Berlin, we integrated using an AI-based algorithm then the polygenic risk and the clinical risk factors. And what it shows to us is that in particular in younger people, you see here, this is sort of the red curve is the higher people with higher polygenic risk scores. So particular in the younger and in the intermediate coronary disease risk group, this is where polygenic risk scores may become important, I think, and we will soon get a consensus document from the ESC on the topic that will, I think, go in that direction. Then, interestingly enough, there is not only the classical risk factor, genetic risk, there is also what is summarized in the exposome. So there are environmental risk factors that are relevant. So in particular, environmental pollution is a risk factor. Then also infectious disease, and we do know that, for example, vaccination against influenza is reducing cardiovascular risk. So this is something else. And then also stress factors. And this, I think, is an area more clearly understood now. Social stress, but also sleep disturbance are risk factors for coronary disease, and largely by impacting on immune regulation. And this now is, at least in mouse studies, I think, better understood. But if you want to have a holistic view on coronary disease, one needs also to take these factors into account. And therefore, I think imaging is, I think, also very important in assessing the individual risk and understand better coronary disease. And what's happening here in the coronary CT is that we now, using AI-based algorithms, can better automatically analyze these images. And here you see, for example, a recent study where the plaque volume was put together, and you see that patients with high plaque volume clearly are the ones who are getting then events over time, whereas if you have a low plaque volume, that's much less likely. And then the group from Oxford in particular, Carlos Antoniades and others, are putting forward this idea of measuring coronary inflammation by using AI-based algorithms in the coronary CT. And you see here also that in addition gives an information on the prognosis. So I think the combination with imaging has high promise in actually getting more precise in the risk prediction and in the intensity of preventive measures that are needed. Now, when we have already coronary disease, of course, we all are aiming for lifestyle optimization, treating of hypertension and the general risk factors. And I think then we need to look more specifically on the individual drivers of disease progression. And here there has been a lot of focus on the atherogenic lipoproteins, which I think they are very important. And what we have learned over the past years is really what are the causal players. And clearly LDL cholesterol, which is probably our main target in prevention of coronary disease presently, is a causal mechanism for disease development and progression, and we can target it now in different ways. But there are also others, lipoprotein(a), which has been very difficult to target. Now there are 3 large-scale clinical trial programs targeting lipoprotein(a) using molecular therapies. And then there are the triglyceride lipoproteins, whereas HDL, which we always consider as a good lipoprotein, likely is not directly causal in the development and progression of coronary disease. Now, what is impressive, if you look at the genetic studies, is the amount of protection that you see. And this is here one example for the PCSK9. It's a study that was done soon after the discovery of PCSK9 as a mechanism of regulation of LDL. You see here in this study, if you have a variation in the PCSK9 gene that lowers LDL moderately to 100 milligram per deciliter, as opposed to the ones that don't have this, you have an almost 90% reduction in the risk of developing coronary disease. And that's quite impressive, and it shows to us that the time exposure to this risk factor is very critical. So we talk now about LDL cholesterol years, and I will show you an example of how actually we might in the future use that to more precisely prevent actually the clinical manifestation of coronary disease. And this was a smaller study, and this is here a very large study, including 2 million people, and what you can see is the same information. The red study, the red line is what we are doing today. So we treat patients with statins, we lower LDL, and we see about 20% risk reduction per 1 millimole LDL reduction. But if you look at the same reduction LDL in the Mendelian randomizations and the genetic study, you see about threefold risk reduction. And that to me tells that it's very important when you actually start with the lowering or the treatment of the risk factor. In this case, in order, or this will determine how much effect you will actually have in preventing the disease. And I think we need to get better individually to predict when we need to start. And if we start earlier, we likely are much more effective in preventing the clinical manifestation of disease. So our colleague, Dr. Brownwood, said you can never be too rich or have too low an LDL. I think that probably applies for the very high risk patients. And you see here, this is, of course, what we are currently targeting in our management of patients with coronary disease to get below 55 milligram per deciliter. And what is the other interesting area, I think, is because we have such a clear genetic understanding now of these mechanisms, we do see the development of nucleic acid-based or molecular therapies, and we have been very actively involved. This is very easily possible for atherogenic lipoproteins because they are produced in the liver, and the liver can now be specifically targeted. So already now 7 years ago, we have published the first patients where we treated the siRNA, with the siRNA for PCSK9, and you see treatment every 6 months leads to a more than 50% reduction in LDL cholesterol. And of course, the important question was here, does it really hold true over longer term, and is it safe over longer term? And these data we have published end of last year in the Lancet, and you see here the long-term experience of the siRNA treatment for lowering LDL, basically the ORIENT-3 study where we treated them an additional 4 years, and it turns out that the effect is basically similar, so there's no loss of effect over time, and there was also thankfully no new safety event in the long-term treatment. So I think this provides interesting perspectives in how we could get more effective in prevention of and treatment of coronary disease. And Dr. Brownwood again did a very nice idea here, published in the European Heart Journal, and that is really how you can become 100 without developing coronary disease. And you need to basically try to limit your LDL lifetime burden to less than 7 grams. That was the idea. And then if you have, for example, familial hypercholesterolemia, you reach this already at the age of 35. You will get your clinical manifestation. If you have an average of somewhat above 100 LDL, you receive your clinical manifestation around 70. And then you can individually decide how can I actually, when should I start to prevent over the lifetime my manifestation of coronary disease. And I think this is behind also the new molecular therapies that we are now seeing in development that really may change completely how we prevent coronary disease. And this is the gene editing of PCSK9. And we have just seen last year the first clinical data, and that would mean just a once-in-a-life treatment. And then for lifetime, you are protected potentially from coronary disease. And this is a Verve study that we have seen. So it's gene editing for PCSK9 using a single intravenous infusion, and you see the results here from the dose escalation study. So it's already feasible to do gene editing for PCSK9 to prevent basically coronary disease. This is a study in patients with familial hypercholesteremia, but clearly the vision of the companies that are developing these treatments is to apply it to a broader population and to have a once in a lifetime, basically preventive treatment approach. Another lipoprotein that I think has been neglected somewhat over the last years is lipoprotein A. So we do know from genetic studies it's causal for coronary disease. It's actually also causal for aortic stenosis, and we do need to measure it. In patients who have it need to be more intensely treated with preventive therapies. And we have now, as I mentioned, ongoing several clinical studies to actually specifically lower lipoprotein A. And one of the areas that's interesting, you will discuss today, as I learned, also aortic valve stenosis, and all what we do now in aortic stenosis is discussed when we do valve replacement. But what we also need to think about, how can we actually medically treat this disease? And lipoprotein A is in about 1/3 of these patients elevated, and a factor of driving progression. We have just started a clinical trial, global clinical trial now, to see whether targeting this can actually slow the rate of progression of aortic stenosis. Now, so I think we need to, when we talk about precision management of coronary disease, we need to look at these different drivers of disease besides LDL, lipoprotein A, the triglyceride lipoproteins. We need to individualize antithrombotic management, and you discussed this already in the meeting here. I think the guidelines give us more flexibility. And I think an area where we probably can achieve more is the area targeting immune modulation. We have now clinically only colchicine, but there are trials underway that hopefully we will be able to more individual target also this causal mechanism. Now, finally, I want to come to the myocardial revascularization, of course, which is the other clinically important area of coronary disease. And we need to differentiate here, of course, for the acute coronary syndrome, where the aim is really to salvage ischemic myocardium, and chronic coronary syndromes, where the aim is largely the improvement of symptoms. And we hope to also be able to reduce long-term cardiac events, but that is not yet shown really clearly in clinical studies. So I think the clinical decision largely is really focusing on improving symptoms. And I think therefore it's so important that we make the procedure as safe as possible. And I saw in your previous session already that you looked at image-guided intervention, and we have performed together with the colleagues from New York the largest study for imaging guidance of coronary interventions, the Illumine 4 study. So patients that were high-risk patients or patients who had high-risk lesions were randomized to OCT guidance and angiography guidance. And because we have not so much time, I just show you, I think, the most interesting finding from that trial, and that was really that imaging guidance reduced clearly the rate of stent thrombosis. The trial actually didn't individually reach the primary endpoint of clinical events because there was a very low revascularization rate in that study, but stent thrombosis was clearly reduced. So I think it shows that it makes a procedure more safe. And just at the EuroPCR meeting now, last week, we presented the data on the impact of OCT guidance of coronary intervention on serious major adverse events, cardiac death, myocardial infarction, stent thrombosis. And you see there was clearly a reduction seen in imaging guidance. And this is just one of the studies we have in the last years, have seen 4 major clinical trials, 3 in the New England Journal, 1 in the Lancet, looking at image guidance of coronary intervention. And we performed the meta-analysis of these studies that was just published 2 months ago in the Lancet. And you see clearly that, and just I think the most important finding, I think, from this analysis is indeed that there was a reduction in cardiac death, and interestingly also in all-cause mortality using image guidance in the range of 50% if you take all the trials together. And that's not very frequent that we see such a reduction in mortality with an intervention. So I think the data really strengthen the importance of image guidance, at least in complex lesions. And already the guidelines gave a 2A recommendation, the recent ACS guidelines for using intracoronary imaging. And I think with the new data that will likely receive even a stronger indication. And that also asks the question, what else we can learn from intracoronary imaging of coronary disease? And you probably have heard of the PREVENT study that was presented at the ACC trial, that actually asks the question in chronic coronary syndromes, is it right that we just go for ischemia and for FFR guidance, or should we actually look also at the plaques and treat the high-risk plaques for actually improving prognosis, not for improving symptoms, but for improving prognosis. And here you see how this is a study coming from Korea. You probably know that in Korea, every coronary intervention is image-guided, so they have a lot of experience there. And you see the criteria, largely it was lesions that had a very high plaque burden, above 70%, and a low minimal lumen area. So it's low lumen area and large plaque burden, largely that they randomized them to preventive PCI. And you see here an example. So this is which was largely, in this case, intravascular ultrasound that was used. And you see here this very large plaque burden and a small minimal lumen area. Here is the coronary angiogram. And you see that this, in the study, they could actually demonstrate that using this image guidance, they could, independent from the FFR, they could improve the outcome of this population, largely actually by preventing urgent revascularization needs in these patients. And this is the first trial showing that, and there are more to come. There are more trials underway. We are also involved in one of these trials that is now further looking into that concept. And I think it may lead to the management that we have, of course, ischemia guidance, but we may also treat very high risk plaques if this is confirmed in additional studies. And so I try to give a little overview on what we need to look and learn in prevention, but also in intervention. Both image guidance is important, both in prevention and in intervention. And I thank you very much that you listened to me.
Thank you, Professor Landmesser, for a very elegant overview of the atherosclerosis traveling from the creation of the plaque until the very management. And I think it's a travel of research for you as well. It's you're probably one of the most, I should say, talented people. You've done research in all sorts of atherosclerosis, now coronary imaging, coronary artery disease, and other areas. And it was a great pleasure to listen to your talk. I don't know if there are any questions before.
There is a question from Dr. Karakounis. You will need to take a microphone on, please, so you can be heard also online. Μπορούμε να δώσουμε ένα μικρόφωνο.
Where we are standing in terms of verifications to modify the immune system. It's a very interesting area. We've seen several publications, but we haven't materialized to any pharmaceutical agents. Where are we standing on that?
Yeah, I think thank you for that question. It's a very important area. And in the Charité, you mentioned the Newsweek ranking, and I always feel it's because of the old Nobel Prize winners that have been working. Dr. Virchow already 150 years ago showed that the atherosclerosis is an inflammatory disease, and we actually still struggling on how we can target the inflammation. Clinically, we have colchicine. There are two large trials that showed actually reduction of the need of revascularization. The problem with the trials is that the mortality kind of went in the wrong direction. It's not significantly increased, but nominally you have a higher mortality. That's why many people don't use wide-scale colchicine. We use it in specific cases. So if we have patients who have, despite optimally controlled other risk factors, they still have progression, then we use colchicine. There was a positive trial, the CANTOS trial, using interleukin-1 beta anti-blocker, and it was effective. It actually, in patients with acute coronary syndrome, had a 30% reduction of events in the follow-up. But the company Novartis decided to develop it for cancer because actually at the same time there was a reduction in the risk of lung cancer, and now it's developed as a lung cancer treatment. It was not now approved for cardiovascular treatment. That's why we don't have a clinically available. And then this the probably most prosperative company in Europe, Novo Nordisk, they have the interleukin-6 inhibitor, and this is now in 3 clinical trials in acute coronary syndrome and in heart failure also. And I hope this interleukin-6, we know from the genetic studies, is in the causal pathway of inflammation in atherosclerosis. So I hope that will be a new treatment. But still, the other downside of targeting inflammation is that you increase the risk somewhat of infection, because of course it's always needed also for infection control. And therefore, probably there, like an antithrombotic treatment, we then probably need to kind of balance the benefit and the risk in a way, and not to treat patients that are on high risk of infections.
There is a question by Dr. Koskinas.
Thank you so much. Thank you. Congratulations for the great talk. I have a question about the risk assessment, and especially in what we call in primary prevention. You very elegantly showed that it is worth starting early with treatment because it makes a larger treatment effect over the course of the life. You showed many tools, for example, genetics or imaging, but still in our guidelines, we're stuck with the clinical scores. We know they're not perfect, so we're not making the step to really refine risk assessment. How do you see the field evolving in 5 or 10 years? What can we expect? What can we hope? Or where should we aim to go in the field of especially preclinical primary prevention? Since we have so many tools available theoretically, but we somehow don't seem to be able to use them in clinical practice.
Costas, I mean, we share the passion for prevention, right? And I think what we have in Germany, for example, we have a healthcare system, 99% of the money is used for treatment and 1% is used for prevention. And I think that has to change, because it's economically the more attractive approach, but also, of course, medically the more. And I think I'm quite convinced that we need to get more active. Imaging, as you mentioned, is not yet so strong in the guidelines. I think, from my perspective, there is strong arguments also for imaging, because we have the big problem of adherence. And if a person has seen its plaque in the carotid or in the coronary artery, we know from randomized studies, they are more adherent to that. And I think we can also more specifically assess the risk. And now we have the photon counting CTs, for example, that have less radiation, they are more precise. So, and it's a Gotthard 2 study, there is a big study in Scandinavia going on, and we are also working on that now. So I hope with that work, we will be able to also introduce imaging more into prevention, and I think it will increase adherence and it will help us to get more specific. The polygenic risk score is there will come an ESC consensus document. I think it's likely to be used for intermediate risk patients to help you, and also maybe there was an idea of actually linking it to the risk factor like hypertension and hypercholesterolemia if you combine it, and that hasn't been done in a very appropriate way. So I think we probably need to work more to have better tools for clinical practice. But overall, I think we need to introduce, or need to make prevention more attractive, let's say, and more also use our technologies that we have.
Can I ask thank you very much. Can I ask a practical question? In Greece, we have more and more widely used CT angiography, coronary angiography by CT, and more people are trained to do that, and we have access to that. Although it's not in the guidelines, there is a trend towards performing this exam even in asymptomatic patients. So do you see a future there that we should do in the same topic of primary prevention? Should we check more the coronary arteries with CT or other measures as primary prevention pathway? And then how do you see this evolving?
Yes, so I think it's actually the same happening in Germany. CT is used actually for looking at stenosis, and this is how it's approved now also. And I think as we learned from the study, stenosis is maybe relevant for symptoms, but likely prognosis is more dependent on your overall plaque volume. I think first thing we can do, if the CT is done, we should actually assess the plaque volume in addition to the question whether there's a stenosis or not, and use it for prevention. I think in the asymptomatic patients, it's not reimbursed also in Germany, so we have already that limitation. Personally, I think at least in the intermediate risk patients, I use it also clinically. So because if we do prevention, it's a lifelong treatment, right? And to make that decision, it makes sense to invest somewhat. And I have also the experience of you probably know also from your practice, you have patients that have left main plaques that look very bad, and then you start with statin and then maybe aspirin and so on. So you can do it much more individualized in a way, I think. And therefore, I think it will come. We will have to probably provide more evidence to convince our scientific community. We will also need to provide or to convince our payers that they actually pay for that. But I do think it's a one-time, investment, and then you can do lifelong prevention based on that. So I think it makes a lot of sense to me.
Okay, can we have the, we thought of extending the question session.
A quick comment as far as concerned the use of CT in the American guidelines. When we assess as a primary prevention, we take the history, the blood pressure, and so on and so on and so. Then there is a provision there, the use of CT to evaluate for possible calcium in patients who have a high risk.
Yeah, so in the US, for example, it's very frequently done. So you have already the recommendation in the guidelines. They do the calcium score, and based on that, they do the recommendation for lipid lowering, for example. And in Europe, in the guidelines, it's not yet so strong, but as you say, in intermediate risk patients.
Well, I think in the European, this and the carotids are the only imaging tests that are sort of recommended for further risk stratification, actually.
There is one question for Dr. Arabadzis.
So to go in line with my previous colleague, we have a lot of patients, hundreds, thousands of patients that they did a CT scan, and we have moderate artery disease, for example, plaques less than 50%. Do you consider this group in primary prevention or in secondary prevention?
Well, I mean, if you ask me, they have already the disease, right? They have already plaque, and then the more plaque volume they have, the higher is the risk what they have. And I would base my decision on how intensely I treat what would be, for example, my LDL target on the amount of plaque. So if there's a lot of plaque already in the coronaries, I consider it like a patient who has coronary disease. If you have very, very little plaque, maybe then you can be a little bit less intense with your approach.
In terms of medication management, but you wouldn't revascularize them on the basis of...
The target of the LDL, maybe that to go, continue the question. What is the target of LDL?
The target is always below 55.
If you have very severe plaque already, I would consider already a target of below 55, and I would consider also that's an individual decision, antiplatelet therapy, depending on the amount of plaque. But that's an area of, let's say, precision medicine.
There are some papers that advocate that when the calcium score is above 100, you should use also aspirin.
Yeah, aspirin is a difficult area because we had this negative trials in primary prevention. On the other hand, the example that you made, if you have very severe coronary plaques, but you just don't have more than 50% stenosis, that's a very, really difficult area, because I think that it's more the plaque load that is prognostically relevant than whether you have one stenosis or not.
Well, that can go on forever because we could have so many questions, but we do appreciate your coming here and talking to us. Thank you very much. Thank you all for the questions.